Today's topic is mucogingival surgery, also known as perioplastic surgery or perioesthetic. So let's start the lecture. What is aesthetic? Aesthetic is concerned with the beauty or art. Aesthetic deals with how something looks. It is pleasant or artful appearance. And in dentistry, we try to improve the appearance of teeth, gingiva, and patient smile. It is combination of art and science to improve the overall appearance of the smile. Let's have a comparison of the two pics given on the screen. In pic number 1, the basic difference between the two pictures is in pic number 1, more of gingiva is being displayed. That is not there in pic number 2. So pic number 2 is more aesthetically appealing. It is more aesthetic. Over here, more of gingiva is displayed. Now let's have a comparison of the two pics. In picture that is given above and the picture that is given below on the screen, the basic difference is in upper pic, more of crown or tooth surface is visible, and in the same patient, the picture shows adequate amount of tooth material is being visible. It is being so with the picture 1 is more aesthetically appealing as compared to the picture 2 because of more tooth display is there in the picture number upper picture that is given. Now let's have a comparison of these two pics. If we look over here, more of pigmentation is there in the picture, and if we look at the picture that is given below on the screen, in the same patient we can see the pigmentation is not there. So which one is more aesthetic? It is aesthetic basically what is aesthetically depend on patient to patient. So if patient says I don't want pigmentation in the gingiva, I want my gingiva to look more pink, then we can remove the pigmentation for the aesthetic demand of the patient. The role of dentist is to give aesthetic smile. Aesthetic dentistry deals with the correction of relationship between the gingiva and the oral mucous membrane, but also focus on improving the overall appearance of the oral cavity. Now coming on to the definition. First definition that we will be discussing is of mucogingival surgery. According to the glossary of periodontal term, mucogingival surgery, they are periodontal surgical procedures designed to correct defect in the morphology, position and or amount of gingiva. So all the surgical procedures that deal with the correction of defect in the three important parameters are there: morphology, position and the amount of gingiva. That was known as mucogingival surgery. It was the term that was introduced by Friedman. In 1996, World Workshop in Clinical Periodontology renamed mucogingival surgery as perioplastic surgery. So After this mucogingival surgery, it was renamed as perioplastic surgery, and the aim was to broaden various areas. Initially, mucogingival surgery was focused only on the morphology, position and the amount of gingiva, but perioplastic surgery, it included aesthetic surgical corrections also. So the terminology was changed to now it includes perio, prosthetic correction, crown lengthening, ridge augmentation, aesthetic surgical correction, coverage of denuded tooth surface, papillar reconstruction, aesthetic surgical correction around the implant, and exposure of unerupted teeth. What is difference between mucogingival therapy and perioplastic surgery? Mucogingival therapy, when the term therapy is there, it's a very broader term. It includes non-surgical and surgical procedures. So important difference is it includes non-surgical like papillar reconstruction by orthodontic and restorative dentistry. But in perioplastic surgery, only surgical procedures of mucogingival therapy was there. Only surgical procedure. Non-surgical procedures were excluded from perioplastic surgery. And the recent terminology that is seen in few of the books is perioesthetic. The important topic that is included in perioesthetic is lip repositioning is also introduced in it. Now the various treatment modalities that we'll be discussing in this mucogingival surgery or perioplastic surgery is gingival recession, crown lengthening, gingival pigmentation, shallow vestibule, aberrant frenum, attached gingiva, aesthetic therapy, that is treatment of gummy smile, exposure of unerupted teeth, loss of interdental papillae, aesthetic surgical correction around dental implants. Coming on to the, first of all, we'll be discussing various parameters of perioesthetic. What is perioesthetic? Essential of smile involve teeth, gingival scaffold and lip framework. Proper proportion and the display of teeth, gingival scaffold and lip framework make the aesthetically pleasing smile. So there is proper display of teeth, gingival scaffold and lip framework make the aesthetic pleasing smile. Periodontal tissues plays an important role in the appearance of smile. While teeth contribute to white aesthetic, the periodontal soft and supporting hard tissue form important tridimensional architecture that can be referred as pink aesthetic. So teeth form the white aesthetic and gums or gingiva forms the pink aesthetic. The appearance of tooth length is largely dependent on correct position of the soft tissues. So the correct position of soft tissues should be there for the proper appearance of tooth length. We'll be discussing smile variable. First of all, smile arch, buccal corridor, amount of gingiva exposure at smiling, presence of gingival and incisal asymmetry, presence of anterosuperior diastema, presence of midline shift and changes in axial proclination, maxillary incisor ratio, size and symmetry. Gingival exposure during smile. It was suggested that 1 to 3 mm of gingival exposure should be present during smiling. Gingival level of upper central and canine should be approximately same, while lateral should be 1 mm shorter as compared to the central incisors and canine. And premolar margin is usually 1 mm shorter than that of canine margin. So 1 to 3 mm of gingival exposure is okay. It is considered good, but more of gingiva if it is getting exposed, then it will be not aesthetically looking good, and it will be considered as a gummy smile. So 1 to 3 mm of gingival exposure should be there during smiling. Gingival zenith. Gingival zenith can be defined as the most apical position of the gingival in a tooth. So it is the most apical position of gingiva. So in this central incisor, this is the gingival zenith of the central incisor, and that of lateral incisor slightly below, and this is the gingival zenith of the canine. Therefore, it sets the tooth most apical limit. It is the most apical limit of the tooth. The gingival zenith is the most apical limit of the tooth, and it greatly influences the perceived shape of the tooth. And this position should not be same in all the anterior teeth. The position should be different in all the anterior teeth. So this is picture showing gingival zenith, most apical position. Gingival design. Gingival margin of central incisor must be leveled or slightly below 0.5 to 1 mm, that of canines. Gingival margin of lateral incisor must be leveled at slightly below 0.5 mm to central incisor. Multidisciplinary treatment is necessary for ideal gingival design adjustment. So the gingival margin, it should be at different level. So this gingival margin, it should be at the different level. Now gingival exposure. Different smile line. The classification according to Tjan. First is high smile line. It is characterized by the total exposure of clinical crown and continuous strip of gingival tissue exposure. So if we look at this picture, this is high smile line, in which total exposure of clinical crown as well as continuous strip of gingiva is exposed. Now medium smile line, characterized by the 75 to approximately 100% exposure of clinical crown, and only interdental papillae is exposed. So in this, only 75 to 100% exposure of the clinical crown and only interdental tissues are there. In low smile line, it is characterized by the clinical crown exposure not greater than 75% and no gingival tissue is exposed. The maximum limit of gingival tissue exposure is 3 mm. Thus, gingival exposure not greater than 3 mm is perfectly acceptable, whereas value greater than 3 mm are considered unaesthetic. Now coming on to the interdental papillae, this is also known as gingival papillae. The papillary tissue occupy 40% of the distance between the gingival zenith and the incisal edge of the tooth. So it occupies 40% of the distance from gingival zenith and the incisal edge. The biological factor that determines the presence of papillae is directly related to underlying alveolar bone. Dentogingival complex, biological width or gingival sulcus. It is the combination of biological width, connective tissue that is there in the gingival sulcus, and the junctional epithelium. The biological width is the human body interface that separates the alveolar bone from the oral cavity. It is an important area where internal tissue defend themselves from external aggression, just like in every mucosa of the body. The combined definition of the connective tissue attachment and junctional epithelium average to 2.04 millimeter. This is known as biological width. So invasion of this zone should not be there in order to have healthy tissues. After invasion of the tissue, a healthy situation will not continue. Instead, it will develop crestal bone loss and gingival recession, or a localized gingival enlargement will be there. So combination of, after the sulcus, it is the combination of junction epithelial dimension and the connective tissue that is there. That is approximately 2 mm. So the margin of any restoration, the distance of margin of any restoration should from the bone should be approximately 2 millimeter. And if this distance is compromised, then there will be bone resorption will be there, or recession will be there, or some enlargement will be there. And clinician should have an idea of dento-gingival complex position in teeth to be intervened in, so that the aesthetic and restorative procedures can have a predictable outcome. Clinician should have adequate knowledge of this biological width in order to have a predictable outcome of the restoration or any aesthetic procedure that is there. So the margin of restoration or crown or any prosthesis, the distance should be from the alveolar bone should be minimum 2 mm. This is known as biological width. Periodontal biotype, it represents a clinical reference to the dimensions and architecture of periodontal tissues over teeth, and also to the resistance and stability of these tissue to restorative and implant procedures. So dimension and architecture of periodontal tissues. Now we will be discussing dimensions and architecture of the gingival tissues. In this we will have a thick gingival biotype and thin gingival biotype. So let us see various differences that will be there. Amount of keratinization. So if the amount of keratin is more, it can bear forces. The predictable outcome of restoration will be there as compared to thin biotype. In thin biotype, less keratinized tissue is present. Metallic substances visible if placed subgingivally. If we place the margin subgingivally, it will be visible. Less favorable tissue stability following implant placement, and it is associated with high scalloform and more triangular tooth form. Less stable and difficult to handle during retraction procedure for impression. Thick biotype, there is more of keratinized tissue present. Metallic structures non-visible if placed subgingivally. More favorable tissue stability associated with flat scalloform, more square tooth form. More stable and easy to handle during retraction procedure for the impression. Coming on to the basic periodontal examination. For aesthetic evaluation, the following are useful consideration. First is photograph. Photograph of a patient should be there in order to have aesthetic evaluation. It provides information needed to access the periodontal aesthetic parameters. We can assess various parameters like lip position, gingival exposure during smiling, gingival zenith, amount of gingiva displayed. Additionally, any soft tissue defects such as recession, papilla loss or lack of keratinized tissue should be photographed per sextant and individually. Now coming on to the model video. The smile dynamic and the relationship of the lip to the exposure of teeth and gum are better evaluated with a video rather than photograph. So video is preferred over photographs. Coming on to the probing. Probing is done to evaluate sulcus, pocket depth and to measure soft tissue conditions such as recession and the amount of keratinized tissue present. Probing can also be used to evaluate the periodontal biotype, to evaluate thick and thin gingival biotype. A thin biotype will allow the dark color of probe to be easily noticed through the marginal tissues. Sometimes bone probing also need to be performed. Intraoral reversible mock-ups are very useful in determining and assessing patient expectation. Make sure the patient expectations are realistic. If the margin needs to be hidden subgingivally, it should remain limited to this sulcus and not violate the biological width. Supra or equigingival restorative margin are always easy to control and keep clean. So reversible mock-up is done, and there are various advantages of doing this. Execution of functional mock-up to fine-tune the aesthetic and achieve the patient desire before finalization of definitive restoration. The use of functional mock-up permit development of patient aesthetic goal intramurally. Thank you so much for watching.